This is Dr. Lindsay Van Dyke, and today we're going to review the handouts that we discuss in clinic about type 2 diabetes. So in short, this is an amazing time in history to have a diagnosis of diabetes because there are so many new technologies that we can use to make life easier and get better outcomes, not just in terms of an A1C, but in terms of weight loss and management, or heart disease, or heart failure, or blood pressure. So there are a number of medications, and most of them are oral, that are more effective for all of these things we just mentioned and your A1C together. And there is some technology that is on the horizon that may convert some drugs that have been historically injectable into oral forms as well. So first, let's review, what does a normal blood sugar look like? In general, when someone is fasting and they're otherwise healthy, their blood sugar, when their blood is drawn from a vein, would be under 100. Typically, a healthy individual would be somewhere between about 80 and 100. Similarly, 2 hours after a meal, the glucose should measure under 140. And we are evolved to tolerate blood sugar up to 180, and that is the point where the kidney will begin spilling out extra sugar. The hemoglobin A1C on somebody without diabetes needs to be less than 5.7. So traditionally, we call that space between 5.7 and 6.5 pre-diabetes. And in that phase, we already know that the long-term consequences to heart and vessels and so on, they have already begun in that early pre-diabetes phase. So the more aggressive interventions we make early on do pay great dividends later, and it buys us more health and time. It's equally important that an endocrinologist is just as aggressive with blood pressure, cholesterol, and bone health, because all of these things are intimately related to having diabetes as well. Now, I feel very strongly that being successful with your diabetes management is about making systematic long-term changes in small pieces. And you want to hit your targets about 80-85% of the time. That's pretty good overall, and that allows you some flexibility to live a normal life. And the really good news is that there's a lot of dietary support and product support nowadays. There's paleo diets, ketogenic diets, gluten-free diets, and all of these food and cooking and product resources to help support your needs for a low glycemic lifestyle. Lifestyle is the cornerstone of all of your success. I cannot underscore that enough. I promise patients that I have enough medication to take care of their diabetes and push that A1C down where it belongs. And if a patient doesn't want to do anything except take medication, absolutely, we can give you as many meds as you need, including ultra-concentrated insulin. But I also underscore that the patient is the captain of the ship, because the more effort that they make in lifestyle, the fewer medications I have to manage them with. And I also feel strongly that this is not about eliminating anything from your life. Diabetes demands your attention, and it's either going to get it now when you are being careful and paying attention to it of your own volition to shift your perspective and adjust your approaches to anticipate your body's needs, or it will demand your attention later in the form of missing toes or dialysis or inability to heal after a surgery. So how does a patient really succeed in their diabetes control? Really, the fundamental principle is we have to see the data. We have to know what kinds of patterns your blood sugars are showing us. So you bring your meter or your sensor to every doctor's appointment. And if you have a Libre sensor or a Dexcom sensor, then it's our job to make sure you are invited to the portal for this clinic so that the data can be transmitted to us directly. Back when you went to diabetes education, they will have taught you about the concept of the naked carbohydrate. Everybody knows what the carbohydrates are, right? Bread, pasta, rice, sugar, okay? So anytime you consume carbohydrates, we don't want to consume them by themselves or in a naked state. We want to pair them with fat, fiber, or protein in order to avoid blood sugar spikes. It's the big excursions in blood sugar that produce the damage to the veins and nerves and so on in our bodies. So we want to avoid those naked carbs and blunt our blood sugar responses to what we eat. We know that reducing baseline body weight by 5 or 10% does dramatically improve insulin sensitivity. And when someone is early in the phase of diagnosis, we know that that kind of loss can actually reverse the diabetes, and if we're able to push your A1C down back toward the normal range, and you are able to hold it there for several years, that can constitute a cure. So it's something worth working toward. Now, moderate exercise will do the same thing. It will improve the insulin sensitivity for days. This is where your Fitbit or your Motive Ring or your Apple Watch really become valuable. Because every time you choose the stairs, the bicycle, or the gym, this is actually money in your pocket. The American Diabetes Association says that we all should be getting 30 to 60 minutes of moderate exercise most days of the week. And they define moderate as being able to walk or jog a mile in 12 to 15 minutes. And I think that that's part of what holds patients back, is that they assume in order to meet their exercise needs, they have to be some triathlete or marathoner, and it's overwhelming. But the truth is that if you are taking a half-hour walk after your largest meal, you are already making significant strides. And remember, that insulin sensitivity will improve for several days. Now, I always tell my patients that I have the pleasure of being pre-diabetic, and I've been learning about the various foods and products and strategies for the last 3-4 years that work for me. And so in your packet that is provided in clinic, I provide a list of the various foods that I'm able to find for myself at pretty much any grocery store or online by Amazon. Things that don't taste bad to me, that are affordable and are easily accessible. So this is important stuff to kind of have in your back pocket in case you're in a corner where you need to use something. And because of this, you'll see that pasta is not off limits, rice is not off limits, but what matters is that you find one of these products that you don't mind eating. So I'm able to make spaghetti, and I'm able to make a Penang curry with rice that I like because I use these other products. Let's talk about rescuing low blood sugars. So we're talking about sugar that's under 70. Number one, everybody with diabetes deserves to have at least one bottle of glucose tablets around the house, in their car, at their office, whatever. You can get a bottle of 50 tablets online on Amazon for about $7. The process of properly rescuing a blood sugar is 3 steps. Number one, you need to consume somewhere between 16 and 20 grams of glucose. That means 4 or 5 glucose tablets, or 6 ounces of juice, or if you don't have either of those things, you can dissolve 4 to 5 packets of sugar in water and drink that. The hardest part about rescuing a blood sugar responsibly is waiting 15 minutes. You have to sit on your hands and set a timer because you feel so badly that your inclination is to pound the entire bottle of Coke or eat all of the glucose tablets. But you have to wait because you got to give the sugar a chance to do its job. After 15 minutes, you recheck that sugar. If it's still under 100, you need to repeat the 3-step process until that blood sugar is greater than 100. Once you're over 100, that's a rescue. So it's time to have a small mixed snack. That would mean something that includes carbohydrates and a protein, or carbohydrates and a fat. This will hold your blood sugar in that normal range. It's really important that we avoid over-treatment because we don't want to have a glucose of 300 or 400 afterward. And we know this because chasing blood sugars is a losing game. Most importantly, I want to know what causes a patient's low blood sugar. Did you miss a meal? Did you go exercise? Did you miscalculate your insulin dose for that meal? We need to find it and correct it so we don't keep experiencing this same problem. An important note is that chocolate is not actually a good rescue for a low blood sugar. Chocolate, in fact, is not a naked carb. It has lots of cocoa butter in it. So I promise you, you are going to get a high blood sugar, but it's not going to happen in the next 15 minutes. Let's talk about a basal bolus insulin regimen. Basal insulin. These are the insulins you take once a day. The common ones are Lantus, Levemir, Toujeo, Tresiba. And let's talk about using this regimen in the context of getting an absolutely perfect blood sugar, right? So for an average diabetes patient who has excellent control, waking up in the morning with a blood sugar of 90 to 120, that's about as good as it gets. These medications that we use act over a long period of time. Their job is to mimic what your pancreas does in the background all day, every day. So it's a very slow-acting, slow-releasing, stable medication. And that means if you make a change to it, it takes several days for the drug to finish its job and be able to notice the change that it has affected. Because of this, we can't make adjustments to it every day. So I tell patients to choose 2 days of the week. These are going to be the only days of the week where you are planning to make changes to your basal insulin. Remember, that's your Lantus, your Levemir, your Tresiba, etc. That once a day injection. So these 2 days of the week cannot be next to one another. And let's pretend, for the sake of an example, that you choose Monday and Thursday. So while you are going about your daily activities and you're checking your blood sugars on the usual schedule, it's only on Mondays and Thursdays that you will use that information to decide if it's time to change your dose of the basal insulin. If you wake up on your Monday or your Thursday and your morning blood sugar is higher than 120, then the next time you dose that basal insulin, you deserve an extra unit or two. Then you continue this new dose for the next couple days while you let it do its job. And when Thursday comes along and you check that morning blood sugar, if you are still above 120, because remember 90 to 120 is perfection, then again you deserve a little bit extra. And you continue to follow that pattern twice a week where you are slowly jogging your dose gradually to the sweet spot. The same rule applies on the opposite end. If you wake up on one of those mornings and your sugar is less than 90, well then we've overshot a little bit and you deserve to reduce your insulin dose. So this process that occurs twice a week can take several weeks or months to get you to your sweet spot, and it can seem like a lot of work, but once you get there, you're mostly going to be in cruise control, unless something else changes. It's important to note that not all patients should have goals that are this strict. They shouldn't have 90 to 120 be their goal, because some patients are sicker than that. Some people deserve more of a cushion on their blood sugars, and maybe waking up between 120 and 150 is more appropriate for you, and that will be what we discussed in clinic. So you can simply trade out those numbers and keep following the same process to find your sweet spot. Now let's talk about mealtime insulin. These are the injections that you do before you eat, and ideally they're supposed to be given 15 minutes before you eat. Usually we're talking about medications like Humalog or Novolog or Apidra. These might be known as insulin Lispro or Aspart. There's a new version of Aspart called Fiasp. And now, of course, on the market is an inhaled insulin called Afrezza. And Afrezza works quite quickly. So that's the one where we actually take it with the first bite of the meal because it's so quick to work. So for most diabetes patients who have a really aggressive blood sugar goal, 2 hours after you eat a meal, making sure your blood sugar is under 150, that's about as good as it gets. And because mealtime insulin is so rapid acting, you can make changes to it on any day. So if you have been given a dose, for example, of 10 units per meal, or whatever your dose is since our last appointment, and you are dosing that and finding that your 2-hour blood sugar after your meal is greater than 140, then the next time you do a meal, it's worth adding another unit or two. The same applies on the other end. If your 2-hour post-meal blood sugar is less than 100, then we need to think about maybe backing off the dose. Some people who are very young and otherwise healthy, they can do fine with a number like that, but it isn't for everybody. And that's what we would talk about the next time in clinic. Let's talk about emergency plans for insulin. What happens if you have lost your insulin, you ran out unexpectedly, somebody took it, for any reason at all, your insulin is gone? If you don't take insulin, odds are great that you're going to end up in the ER. And we want to keep you from having to do that. So the first plan should always be call the pharmacy, get a refill. If you can't get a refill from them, you call the clinic to get a new prescription sent. If you can't reach anybody to take care of your insulin needs, here's what you do. All pharmacies in this country should stock an old form of insulin called NPH. And in our state, in Texas, you do not need a prescription to get NPH or the needles and syringes over the counter. Any pharmacy should supply this, but Walmart typically has the best price. You can get one vial of this NPH for about $25. So if you're in this position where you need to take this NPH insulin until you can get a hold of us or your pharmacist to go back to your regular insulin regimen, you're going to give yourself half of your usual dose of this NPH insulin every 12 hours. It doesn't take very much insulin at all to keep somebody out of diabetic ketoacidosis and keep them out of the hospital. Your blood sugar may not look great at all, but it's a Band-Aid to get you through until you can go right back to your usual regimen. Family planning. This is really important for women with diabetes. About half of all pregnancies in the United States are unplanned. And if we let that happen with a patient who has diabetes that is not perfectly controlled, there are significant risks to both mother and baby. And a lot of these things can happen in those very early weeks of pregnancy before anybody knows. That's when all of the baby's organs and nervous system are forming, and having high blood sugar during that time can be quite dangerous. If high blood sugar is persistent through a whole pregnancy, then it leads to a number of other risks for mom and baby, because sometimes the babies can get quite big, and that can make delivery difficult or require C-sections or run into other complications. So it's really fundamental for moms and babies' safety to plan for conception appropriately. And when we're getting ready for pregnancy, we want to make sure that that A1C achieves a very strict goal, somewhere between 6 and 6.5%. So if a patient is not ready for pregnancy, there are so many options available for reliable contraception. The intrauterine device, or IUD, there are a number of different kinds, some hormonal, some not. Progesterone implants, also extremely reliable. There's the contraceptive pill. There are injections, vaginal rings with contraceptive hormones. Of course, if you're done with having children, there's permanent sterilization for either mom or the partner. It just depends on your needs and preferences. But we always want to plan ahead for safety. What can patients do to make their lives easier and get better control? This part has to do with all this technology that I have been referring to early on. So number one, take medications as prescribed and do not miss doses. That's a huge part of winning at the diabetes game. Number two, like we previously discussed, you have to bring the data to the appointment, either transmitting it wirelessly through the portal, through your sensor, or bringing logs where it's all written out, or at minimum bringing the glucometer so we can flip through and see the kinds of numbers you have. If you don't know about the sensors, I'm going to tell you about the Dexcom, and there is the Freestyle Libre. So Dexcom is an advanced sensor, they're in their 6th generation now, that checks blood sugar automatically every 5 minutes or so. It can communicate with insulin pumps, and its major benefit is that it will alert you if you are having a low blood sugar or if you are quickly on your way to having a low blood sugar. So for people who can't feel low blood sugars anymore, this is a cornerstone of safety for them. The Freestyle Libre is not quite there yet, but it's a wonderfully accessible device that is in fact more precise than any finger stick that's out there. It automatically checks blood sugar every 60 seconds. The device is worn for 14 days at a time. The cash price at Walmart is about $35 or so. You see your blood sugar reading when you scan the sensor with either the device that comes with it or with your phone if you have an iPhone 7 or higher. For both of these sensors, a number of commercial insurances and Medicare will pay for them as long as we jump through the right hoops. There is a new sensor on the market. It's made by a company called Senseonics, and the sensor itself is called Eversense. It has been in Europe already, but about midway through 2018, it was approved in the United States to be worn for 90 days at a time. This particular sensor is unique in that it is implantable under the skin. So some patients who say are deaf and they cannot hear the Dexcom alerts, this is a good choice for them because instead of making noise, this sensor will vibrate. It does communicate with a transmitter that's worn on the body. This is like wearing a sticker, so it can be put on and taken off as needed. As always, you should utilize other resources when you have questions or you want to learn more, but those resources need to be peer-reviewed and reliable. So you can always check out the American Diabetes Association at diabetes.org, the Centers for Disease Control at cdc.gov, the National Institutes of Health at nih.gov, and of course the Mayo Clinic at mayoclinic.org.